Good day, colleagues. I'm excited to share with you today my tech talk. My name is Tiffany Cox, and I'll be speaking with you in regards to factoring Moulage authenticity. My disclosures are here as listed, and while unrelated and not a conflict of interest for our discussion today, I do receive and channel back into resident training programs royalties for an endoscopic training system for colonoscopy. The objectives are as listed here in regards to, we'll review the current research about moulage and simulation, as well as what is authenticity and what level is it necessary in simulation, and then new frontiers or future directions.
So Dr. Jessica Stokes-Parrish is the biggest author really in moulage and simulation. She is actually an ICU nurse, and she has her PhD in simulation education. So she's an associate dean somewhere right now, and she's recruiting and training and teaching future for these types of efforts and evolutions. So here, the three papers that we'll kind of hit on are listed here. Our most recent just this year. But as I said, we'll kind of gloss over these things, but I will tell you, this is embedded in within one of my weeks within this MPS course specifically, and I delved further into some of her more recent papers she's mentioned, and just really got interested in it. I'm not saying that the research impressed me, but just the concept and ideas. When you do moulage, how far do you have to take it? What's distracting or can then disengage the learner? What keeps the learner on target? And what's the whole point of doing it? And then a little bit about, does it affect their ability to improve their clinical outcome within the simulation or not? So, for her Delphi study, when we talk about Delphi study, what does it exactly mean? So in this particular case, she paneled out 31 experts. 18 of them responded, but only 10 made it to round 5. So essentially what happens is you reach out to the experts and you say, okay, on the topic of moulage and simulation, what do you think is going to give me back comments are some of the key components that we need to focus on. And then they put all that together, and then they utilized, I think I put on here Deckerman's, theory of realism. So just to hit on those 3 topics, so categorized within what was the feedback from them to say, when we talk about some of the earlier writings, our author, Deckerman, wrote a paper in 2007, kind of utilizing the ideas of learning theory, but replacing it into simulation and how do we apply that to realism. And so the 3 categories there listed: physical, so what is more textures, colors, how is it that we get you to believe that it's reality physically from seeing it? Semantical, so the learner, how are you creating as a whole that their relationship with whatever activity or story is being told, they're buying into that, and that's where, if you've never heard the term fictional contract, so the learner, the proctor, they're both understanding that this isn't a real scenario, so you accept certain things, like the mannequin looks plastic, or you're placing it next to the IV, but you're not actually inserting it on patients, those kinds of things. So that's that fictional contract. And then phenomenal, so that idea of you're now emotionally engaging them. You feel like bad, you see this huge broken leg, and it's like, oh, you know that person's hurting, and so perhaps then that makes you get more empathetic towards what's happening and more acuity to the situation and treating that. So these are the lines in which, once they gotten all those comments, then they placed it within these realms, and then pushed it back out through 5 different rounds of questions, and then they had a benchmark of 80% that they want, and then pushed it back out through 5 different rounds of questions, and then they had a benchmark of 80% that they wanted each category to hit within the rounds, and once it met that benchmark, then they started to include it within their hard and criteria to then form actually an authenticity survey to be able to then output for the study. So I just cut to the chase on rounds 3 through 5. So those that met round 3 position, so where, did they have it? Was it kind of accurate detail? That's a broad term, but I think it's more so like, as you see at the top, color, the detail hit them more importantly than color being that. Were you giving kind of that gradation to it? Likeness to the real world, you can't use maybe all the colors of the rainbow, things that sort of are more similar, so you believe maybe that like depth and shadowing, so you're giving it to more real likeness. Anatomically correct, we're putting it on the right part for the right thing. That injury could actually happen in that area. Moulage fits logically within the scenario. You're not going to have, maybe a gunshot wound and it looks like there's an IED blast injury, right? We got to fit within. You place the scenario. So that's not always just on the moulage, right? That's going to be that partnership with the proctor telling the moulage artist that what it is you need in the scenario. And I do apologize if you came here thinking you were going to learn how to do moulage. I'm more telling you how to use it, but so moulage presented as part of a proper scene. Sometimes it's not just on the person. Maybe there's other parts or blood in the scene, that kind of stuff that you need to be mindful of. You're trying to convince somebody of ongoing bleeding here. If you don't have a mechanic to do that, especially in a live patient, if you have a huge pool of blood, then that might then remind the learner they've lost a lot of blood, not just a few spittles on the neck, something like that. Moulage is a sufficient level to not to distract or confuse the participant. Sometimes it can be so good. They talked recently about deception in simulation, as if, whether it's the learner feels like there's a hidden underlying, agenda within the simulation, or they're just dissociated because perhaps it looks too real or not real enough. So you don't want to distract you, and this is where I get into, you want to be able to capture it enough. This is what she talks about in some of her podcasts as well, so that you are getting the learner to move on to the next step, but not so much that they're like really trying to find some other injury within it, like too detailed within the wound, that now they're off track from the usual steps they need to be on. Moulage well timed, where appropriate, and fits within the scenario. Those are things all the way back good. And then color kind of came up in that round 4, so that's when the threshold was met, meaning it's not as important as some of all those other details, but important enough to hit the top 13. And then our last categories, we had size, shape, and simulation orientation to mitigate low realism. So that's in line with some of the things I had mentioned. What I found interesting, are actually the ones that weren't included. So you look at depth, scale, and texture. The other things are more sensorium, smell, and things that, it's been studied, but nothing has ever proven that that's going to be the thing that now the learner catches on to. So been looked at, and, from the soft literature out there, it's not worth it, the efforts to put in to make that happen. I will say of our recent MassCal event that we did for JTS on Tuesday, we did have gunshot wound, or gunshots going off at the time of the evolution. And it was more to remind learners, like, you're on the X. Like, you can only render or need to render so much care on the X, and then you need to get them out, rather than trying to make them think, oh, where are they coming from, and so that was part of that. But back to what was otherwise not important, depth, scale, and texture. We'll delve into a little bit on tattoo, and I find it interesting that all this is in line with that. If you're using a tattoo kind of wound, depth, scale, and texture, it doesn't affect that. So you can get that realism, get that effort, get the cues to move on, and these were things that even the experts found weren't important. Create this Moulage authenticity scale, and her further studies then utilized this, that top 13, to then gradiate out from the learners, how did you feel like the authenticity of this was? She then took it on, I think it's 2019, so a couple years after, the 33 medical students in 3 arms. Had control, no moulage, only the proctor talking, low authenticity and high authenticity. So how did that affect their clinical abilities? So there's no difference, actually, the clinical action. So that is assuming that all the proctors, all the facilitators are saying the same storyline, the same prompts, the same cues throughout. That's really the biggest consistency that needs to be happening, especially in scenario simulation. And then time to treat was no different. You would think, oh, okay, now they see a huge wound, maybe they're going to act quicker, versus I'm telling you this leg is broken, acts now. It wasn't a significant difference of time to treat. Also, be mindful, 33 in total, that's going to be 9 to 10 per group. So again, this is where that, they're looking at it, but it's still soft numbers to be able to hold that hard and fast what makes a difference. And then feedback from learners, though, this is where we're looking at what did they think about the authenticity, as well as they had a iris survey, basically like what was your engagement within it? Did it make you engage more within the simulation? And their primary themes of what they felt were comments to within each group is that within that medium or getting some authenticity but not the highest levels, you're wanting to follow like the rules of simulation. So how are you able to get that fictional contract right and get it to where you're believing, but it's not over the top? Believability of the scenario, consistency of presentation, as I mentioned, that the proctor, it was important. They wanted to see that each learner was getting treated essentially the same, right? No bias. And then whatever personal knowledge they kind of already had, sometimes that affected their impression of the scenario. They could see perhaps more what the wound would look like if they've seen it before, those kind of things. Then secondary or sub-themes, awareness of simulating. Sometimes, again, going back into that deception, sometimes, especially a new learner to simulation, they'll be like, is that actually part of the simulation, or is this something happening? You know, like you have, there was an example of like they were going to say, okay, we're preparing for earthquake mass caldrill, and then all of a sudden somebody's having a heart attack, and so you know you want to fit it within the storyline because then they're worried, is this person actually having a heart attack or not? And they were trying to say, no, we just wanted to mobilize the team. So this is where you have to really, you can't go so far out. And I'll take a moment to also say pre-brief is very important. So let's say you do something of that nature. You need to be including that in the pre-brief. Be prepared for possible scenarios where individuals might react. And so then if they did have that reaction to something happening there, then, you know, that's more believable into that fictional contract. Oh, they told me that there's a possibility of this happening. And so those rules of engagement are already in place. And the other sub-themes there is hidden kind of, they delve and cross over a lot. The hidden agenda I kind of had missed, or they missed something. This really fell deeply into the actual verbal comments they made. Was like, if the proctor kept saying something, I felt like I was missing it. Whereas sometimes we actually say it because we want to ensure that the learner knows they achieved it, that we acknowledge that they did that rendering of care. So again, if that's something where you're seeing common themes of that as a problem, that might be part of something you need to formulate what you're going to say in your pre-brief to say, you know, we may tell you this because we want you to know we have captured that you've completed that task. Systematic review. That's where the compilation, it was 20 different studies and a total of over 11,000 learners included to be able to look at where do we see the impact of this. And so improvement in learner satisfaction is there. They improved in their confidence, immersion within the task. We kind of talked about self-efficacy. So as they believe it, then they feel more confident, but they know that they can carry that task outside of the room. So maybe they're not improving on the time, but they actually intrinsically know, hey, I feel more confident of it because they have had a level of authenticity that makes them believe if they saw that wound again, they could treat it, not just a theoretical, the wound was there and I did it. And then that empathy, as we kind of talked about, enough to believe that it's happening might make the providers more into the scenario. They even talked about how, you know, if there's some like, you want people to use PPE, almost always when there was some low to higher authenticity of the wounds and moulage, people were putting on gloves, putting on gowns, versus not having that. They were just kind of touching all over and it wasn't a big deal. So if that's something important you need to drill down on, you need to use a level of authenticity to do that. Not impact the learners. So as we kind of said, it's not their clinical performance that you're sometimes improving. One important thing I didn't actually mention in any of this was team dynamics and team training. Does it affect your ability to train as a team? That may be a clinical performance aspect because a lot of these just honed in on the individual things with it. So you can definitely a few definitions that they defined within she defined within the paper I thought were worth saying because, as you know, when things kind of move along, I do feel like simulation is moving along in its rhythm of trying to be more, you know, accredited with their research. Then I think common terms are going to come up. So engagement would be the state in which the participant is observed to be actively interacting with the simulation. So getting those visual cues to guide them to the actions, but not disrupting the flow in which you want them to engage. Versus immersion, they're participating within it. We have this type of problem sometimes, whether it's a new learner and they're overwhelmed, and so, or they just because they could tell it's a mannequin, now they have no interest in it, right? Versus a more experienced learner or somebody who's done simulation before, they're over that issue of it being a mannequin, and they can immerse themselves more into the situation as possible. There's also some more frontier research in future directions if you're looking into how to improve and what papers are being asked, and probably how she's already, her PhD candidates, getting them involved in different directions. These are the things that are going to be up and coming of where the level of the studies would go. So, you want to see pictures? I mean, that's what we came for, right? Okay. So, what I would like to say is all these pictures you're about to see are all ones of simulation we've done here. So these are by our guys, including our volunteers, all within the command the last 3 years. So, so here, this is not actually, you can touch up on the top, but these are actually like straps that you could put on the leg. So they're already pre-designed wounds to be able to give you that feel, and you can place it in different spots as you need it. All artist touch. Again, we've used like ID blast in the building, and a pencil shits in the neck, all the kinds of things that you can do, and then how to kind of curtail that in. If you're wanting to get that impression again of not only is it an airway issue, but it's a bleeding issue, this is where then you should really have one that's covered in blood and blood on the floor, because you're not going to be able to get that squirt effect on over time. Okay, and here, very well done job for the, and all these pictures actually were just from Tuesday, the one we did over in the gunshot wound to the chest. So now he's got this tension pneumo, or even giving a little bit of like cyanosis kind of feel. So, and as you can kind of see, it's also a little bit of the believability of the simulated patients, and thankfully, because we've done this in a repetitious manner, people want to keep volunteering. They're always raising their hand, and so they want to engage. And we take the time before, the evolution starts every time to have not only a safety contract, so we have all of the simulated patients sign to say what they're agreeing to. We have the proctor sign to say they're doing the one-to-one. I'm doing the safety monitoring for you, as well as include a statement if it's like one of those times where we're letting them put IDs in, so that there's an understanding for the simulated patient of what they're agreeing to. And then being able to talk one-on-one with the proctor, what do we see the scene doing ahead of time? And I meet with the proctors ahead of time as well, even before that, so that they know, okay, this is how your scenario goes, and then troubleshoot. If they don't do these actions, this is the direction you want to go with those. So this is one of the innovative projects of his recent burn, and how to make that kind of look more like a leathery skin, and what to utilize with the types of papers and things you can do, and the discoloring of that. And that's how that looked, out in the field. So that was an excellent job. Here's our live patient, here's our live patient. So as soon as they got to the point, the learner, that they needed to do a task, you have a couple options, but here I'm demonstrating that you can then have with you as the proctor a task trainer. So now we're utilizing the ability, and this is pre-moulaged packets that you can then put on. That that's the same injury you just saw on the other patient, and so now you're needing to insert that airway for the patient. Same thing, you knew you needed a needle D here, and so now they're being able to practice. And again, this is just from this week. This was from our FinX last year for JTI housing buildings, and so I wanted to highlight here other capabilities from SimCenter. So this is our cut suit. And so you can have that full rib cage here where you can simulate, instill things so that, you have some stuff coming out. And then I think the next slide I've highlighted, yeah. So she's actually wearing, this is a shout out to DSS. She's a willing volunteer to help instructor. But, here you see the airway plate. So there's a hard metal plate underneath. So not only is one, Neuronus was the one that covered this at that time, he's trained in how to use the cut suit. So using the cut suit, you have to be trained in knowing how to use the equipment. But then two, having that one-to-one safety monitor, again, knowing when's the time to cut, and if there's any cut issues. But the plate's really extremely protective. That's why it's designed and safe to use on an actual patient. So then they can continue to give those effects as you're doing it, which might add into a little bit of that, you need that kind of tense situation, because you don't want it to just be usual where nobody's moving or doing anything on a simulator, you can kind of add that component in if that's the level the learners can learn at. It doesn't always have to be uber complicated. They may not. You need to have enough to get them interested, but it can also then be, oh well, it's broken. What are other clinical things I need to check on? So it's not so distracting by a million injuries. Let's focus and get this one right. So that's as effective, and you can see here as well. And most of the time, these types of scenarios, I'll also make them screaming and hilarious. So then they have that more psychological component to treatment. Then you can treat the single injury. And here you can even see, well, it doesn't take much moulage. We just have a little bit of bruise in the chest. We had these guys totally engaged in the scenario. And again, I think a lot of that attributes to the prep for the patient, simulate patient ahead of time on how to make that moulage work for you. And example of some really well done moulage from HM1 Kitchen in the past. This was last year for our midway FinX for the JTS. So, and then not only do you have the component of this, but as you can see, we kind of put them on the bleachers and then how to get the patient down safely if they have an injury and some such in there. Just kind of trains them for those. So new frontiers in moulage. I really want to talk about tattooing. You can kind of see there scattered amongst anybody who wants little gifts or presents of any kind of trauma tattoos there for gunshot wounds and things of the nature. This is something that I want to kind of utilize in the future for some of what we do, just to see how effective it is and in comparison to some of the nuts and bolts of what we have been using. But it doesn't just extend to trauma, and in fact, there's really no literature on trauma tattoos. It's more so, especially with the derm stuff, they've been using that so you can fake it and then you come in, so it's like the OSCE, and now you actually have something to look at, not just like I have red bumps on my hand, but the learner sees it and maybe that cues them in more to, oh, this is an issue, or if you had some subungual, this doesn't show like a cancer, but my thought was that'd be really useful. You have some kind of weird cancer or lesion scan, and then they can say what's concerning, what's not. Uh, as mentioned before, this is what augmented reality looks like. So I don't know if any of you have been to. The only best example I've ever been to is in Barcelona and the Gaudi House. You go through and you hold up the tablet, okay, and now you're also seeing things within the room, even though the room looks as if it is, but you put it up and things are starting to happen. It looks like what it used to. So that's similar to here in that they can then take a tablet and they've this particular pilot study done. They have coders involved, and so they were using Photoshop and some laser beam SX programming, okay, things way outside of my scope, but all to say they wanted to pilot it, see if it was usable, to then this could be something out forthcoming, a more larger scale. You could overlay that on whatever mannequin you have and then plug and play different injuries and wounds. Which might be more adaptable even compared to, we have a great simulator SimMan upstairs that programs, but sometimes those can lag and then get outdated for the programs to actually work. And so this might be a quicker way to get that with less overhead of physical knowledge.
So with all that in mind, I just want to thank you for your time and attention today, and I look forward to hearing all about your tech talks.